Ischemic heart disease. Today we will talk about everything about ischemic heart disease. First of all, pathophysiology of ischemic heart disease. Then clinical features or clinical manifestations of ischemic heart disease. Investigation done in case of ischemic heart disease. Indications for surgery. That means when surgery is needed. Then preparation for surgery. Selection of conduit. The operation. Next, post-operative recovery. And post-operative complications. And surgical outcomes. These are the topics discussed under ischemic heart disease. Investigations are of two types: non-invasive and invasive. Non-invasive investigations are resting ECG, troponin and cardiac isoenzymes, ETT, echo, radionuclide and cardiac MRI, positron emission tomography and CT. Invasive investigation is coronary angiogram. Indications for surgery. In case of chronic stable angina, acute coronary syndrome, then surgery for complications. Preparation for surgery. These are clinical assessment and risk assessment. Selection of conduit includes venous graft and arterial graft. Complications of operation or post-operative complications. Post-operative complications include bleeding, arrhythmias, poor cardiac output, neurological dysfunction, wound infection, and mortality. Surgical outcomes include relief of symptoms and survival. So now we will go to the description. Ischemic heart disease. Ischemic heart disease is a major cause of morbidity and mortality in resource-rich countries. The underlying pathology is mainly atherosclerosis of coronary artery. Atherosclerosis of coronary arteries. Now pathophysiology. Our first topic, pathophysiology. Atherosclerosis is the process underlying the formation of focal obstruction or plaque in large or medium-sized artery. So atherosclerosis is the process underlying the formation of focal obstruction of plaques in large or medium sized artery. There will be formation of plaque. It is accepted that atherosclerosis is a chronic inflammatory process. So it is a chronic inflammatory process. Chronic inflammatory process resulting from interactions between plasma proteins, leukocytes, T lymphocytes, vascular endothelial cells, and smooth muscle cells. So, if we repeat, it is accepted that atherosclerosis is a chronic inflammatory process resulting from interactions between plasma lipoproteins, leukocytes, monocytes or leukocytes include monocyte or macrophage, T lymphocytes, vascular endothelial cells, and smooth muscle cells. Atherosclerotic lesions can histologically be found at different stages in blood vessels, including the fatty streak, fibrous plaque, and complicated lesion. The fatty streak. The first evidence of atherosclerosis. The first evidence of atherosclerosis can be found in children 10 to 14 years of age. This appears as a yellow streak running along the major arteries. This is yellow streak running along the major arteries. The streak consists of smooth muscle cells, smooth muscle cells are filled with cholesterol and foam cell. Then fibrous plaque. A fibrous plaque consists of large number of smooth muscle cells, foam cells, and leukocytes. As the fibrous plaque grows, it projects into the vessel, leading to the lumen narrowing. In turn, can lead to ischemia or infarction. As the fibrous plaque grows, it projects into the vessel. Into the vessels, leading to lumen narrowing. Lumen is being narrowing. That in turn can lead to ischemia or infarct. Complicated lesion. This occurs when fibrous plaque ruptures. When this fibrous plaque ruptures, provoking activation of coagulation cascade and the formation of thrombus. And the formation of thrombus. Now, risk factors for ischemic heart disease. Risk factors include advancing age, male gender, hyperlipidemia, diabetes mellitus, hypertension, smoking, family history of ischemic heart disease, obesity, and reduced physical activity. Now, clinical manifestations. Clinical features or clinical manifestations. The principal symptoms of ischemic heart diseases are chest pain or angina. Number one, chest pain or angina, breathlessness. Number C, fatigue. Number 3, fatigue. Number 4, swelling, palpitations, and syncope. Severity of symptoms and extent to which the symptoms interfere with everyday activities from a significant part of clinical history. An assessment of risk factors should be included. Clinical examination follows, and although often normal, any evidence of myocardial ischemia or stigmata of the associated disease, such as diabetes or peripheral vascular disease, or peripheral vascular disease should be noted. Investigations includes both invasives and non-invasives. Invasive. Non-invasive examination or investigations are resting ECG, troponin and cardiac enzymes, ETT, echo, radionuclide and cardiac MRI, positron emission tomography, and CT scan. Invasive procedure includes coronary angiography. Only one. Non-invasive are at number 1, resting ECG. As a baseline test, a 12-lead resting electrocardiogram or ECG often provides the first indication of ischemic heart disease and essential in the acute clinical setting. However, it is not necessarily abnormal even in the presence of severe multivessel coronary disease. Evidence of previously myocardial infarction is seen commonly as QAFs or non-specific ST and TOF changes. It's commonly seen in QAFs and or non-specific ST and TOF changes. Troponin and cardiac isoenzymes. Number 2, troponin and cardiac isoenzyme. Troponin and cardiac isoenzymes. The results are useful in assessing patients with an acute coronary syndrome When diagnosis is in doubt, standard enzyme measurements troponin, such as troponin and creatine kinase MB, that means CKMB, and lactate dehydrogenase can aid diagnosis as well as having prognostic complications. Number 3, exercise tolerance test or ETT. Exercise tolerance test or ETT. Exercise tolerance test is a valuable technique for assessing myocardial ischemia, both for diagnostic purpose and for prognostic purpose. However, an abnormal exercise test must be interpreted in the light of the probability of coronary artery disease and the physiological response to exercise as measured by the percentage of the maximum predicted heart rate achieved. A positive test with evidence of ischemia on ECG, that means ST depression, depression of less equal 2 millimeter does not always indicate ischemic heart disease, and a negative test does not always exclude its presence, Then echocardiography, or number 4, echocardiography, in short echo, performed either through a transthoracic or transesophageal approach. Transthoracic or transesophageal approach. Echocardiography is valuable for the evaluation of ventricular function and regional wall motion abnormalities, as well as valvular lesions. Stress echocardiogram can detect regional wall motion abnormalities brought on by exercise or the use of dobutamine or dipyridamole. Stress echocardiography can detect regional wall motion abnormalities. Regional wall motion abnormalities brought on exercise or the use of dobutamine or dipyridamole. It is reliable method of identifying viable myocardium. Impaired but recoverable myocardium possesses a functional reserve that allows it to be temporarily recruited into action, whereas scar tissue does not. The development of real-time three-dimensional echocardiography, with the ability to carry out valve reconstruction from different aspects has recently revolutionized preoperative surgical planning in patients with complex valvular lesions. Valve reconstruction. It helps in valve reconstruction from different aspects has recently revolutionized preoperative surgical planning in patients with complex valvular lesions. Number 5, Number 5, radionuclides, radionuclides, nuclide studies, and cardiac magnetic resonance imaging. Number 5, radionuclide studies and cardiac magnetic resonance imaging. The main type of radionuclide studies, radionuclide study used is myocardial perfusion scanning using specific radioisotopes such as thallium 201 to assess the significance of coronary artery disease and viability of myocardium. Cardiac magnetic resonance imaging can be performed to evaluate the ischemic burden of the coronary disease using pharmacological agents to stress the heart. It can be performed to evaluate the ischemic burden of coronary disease. Ischemic burden. And to provide details of tissue viability when using gadolinium as a contrast agent. Gadolinium is used as a contrast agent. MRI is also useful in assessing cardiac tumors, pericarditis, and other structural heart disease. It also helps in assessing number 1, cardiac tumors, pericarditis, and other structural heart disease. Number 6, proton emission tomography. Proton emission tomography. Proton emission tomography provides information on myocardial perfusion, metabolism, and cell membrane function. It gives information about myocardial perfusion, metabolism, and cell membrane function. Positron emission isotopes are used to label physiological substance which can measure the regional distribution of these substances. Positron emission tomography is valuable in the diagnosis of coronary artery disease, particularly when the more widely available imaging modalities are inconclusive. It can identify injured but viable myocardium that is potentially salvageable by revascularization. It can identify the injured myocardium. Injured but viable myocardium. Number 6 done. Next, computed tomography. Computed tomography or CT. With the development of latest computed tomography scanners which have the ability to correct the respiratory and cardiac movements, multi-slide high-resolution CT scanning may become an alternative to coronary angiography. It allows assessment of coronary disease, particularly proximal coronary artery disease, and gives some information about the degree of coronary artery calcification or calcium sore. Proximal coronary artery disease and gives some information about the degree of coronary artery calcification or calcium sore. That is very helpful when stratifying patients to determine which one will benefit from the more invasive coronary angiography. Now, invasive, non-invasive methods are done. Now, invasive methods of diagnosis: coronary angiography. Invasive methods of diagnosis include coronary angiography, coronary angiography. Selective coronary angiography provides the means of accurately diagnosing the presence and extent of coronary artery disease and remains the gold standard diagnostic technique. Remains the gold standard diagnostic technique. This coronary angiogram demonstrating severe stenosis in the left main stem prior to bifurcation of the left anterior descending and circumflex artery. This is the severe stenosis. In the left main stem prior to bifurcation of the left anterior descending and circumflex artery. Left anterior descending and circumflex artery. In spite of the availability of newer imaging techniques such as cardiac MRI, selective coronary angiography provides selective coronary angiography provides high image quality, demonstrating the extent, severity, and location of the coronary artery stenosis and the quality and size of the distal coronary arteries. Any stenosis in an artery greater than 70% of the diameter, 90% reduction of the cross-sectional area is considered severe. Any stenosis in an artery greater than 70% of the diameter or 90% reduction of cross-sectional area is considered as severe. In addition, angiography can assess ventricular function and provide the cardiac surgeon with information to determine the operative risk and probability of the operative result. Coronary angiography only outlines the coronary anatomy, does not demonstrate ischemia, and carries an overall complication rate of less than 1%. However, flow measurement across a stenotic area using techniques such as functional flow reserve FFR has been effective in predicting patients who are likely to benefit from revascularization. Moreover, intravenous ultrasound can provide more detailed information regarding the degree of stenosis, especially in left main stem disease. Coronary angiography is the gold standard for imaging of anatomy, demonstrates extent, severity, and location of stenosis. Extent, severity, and location of the stenosis. Reduction in diameter at more than 70% is considered severe. 90% reduction in cross-sectional area. Demonstrate quality and size of the distal arterial tree. Quality and size of the distal arterial tree. Aids the diagnosis of ischemia. Evaluates suitability for surgery. Aids in prognostic assessment.